Well, thank you, everybody, and thank you particularly to the RNIB for inviting me to talk here today. I feel very privileged to come and talk to a group of hardworking GPs. I do know how hard you work. My former life is as a practice manager in a GP surgery. I worked there for almost 17 years. So I know how hard you work and that you give up your days to come on study days like this and the impact it does have when you go back to the surgery. So as I say, I'm very grateful to be able to talk to you as a captive audience and talk to you particularly as a patient and especially as a visually impaired patient. My name is Liz. And when I was 26, I had an accident in my left eye, which completely knocked out all of my central vision. I just see very peripherally in my left eye. I have a very ragged scar. And at that point, there was really no treatment available to me. Then when I was 40, I was told that I had AMD. Who knows what AMD is? Good. Who knows what the classic signs are of AMD? What is it before it gets to that? Exactly. So what your patients may come to you with is, I can't see a straight line anymore, it's got a wiggle in it. So I noticed this wiggle in my straight lines, and rather than coming to my GP, I actually went first of all to my opticians. So I bypassed the surgery at that point, and my optician was really on the ball and got me sent up straight away to the eye casualty. I come from Sheffield. There's a superb eye casualty and ophthalmic clinic there, and I was seen in the clinic. At that point, I just had the wiggly lines. And basically, they just said, we will monitor you, go away, and we will keep an eye on you. 2 weeks later, I was sat at home alone, about 10:30 in the evening, and something massive and extraordinary happened to my right eye, of which I had no understanding of what had happened, other than my vision had completely and utterly become distorted. I was so frightened. That then began my journey in secondary care through investigations and treatment. And I had, at that point, it was something called photodynamic laser therapy treatment. And then later on, about 5 years later, I then had to have the eye injections, which have been touched upon earlier on this morning. They aren't pleasant, I have to say. If any of your patients do come to you and they are anxious before the onset of their treatment, please try and support them as best as you can. It's a very frightening and upsetting experience to have to go through. There are lots of support agencies available to you to pass them on to, the RNIB, the Macular Society. They have great support and they can literally tell your patients what to expect if you don't know that yourselves. Anyway, getting back. So, my first encounter with my GP after about a month, because as I say, 2 weeks had elapsed from my wiggly eye to the massive hemorrhage that I subsequently had. And I couldn't see, I couldn't work. I was a practice manager in my surgery and I couldn't see anything, I couldn't work. I had to go and get a sick note for work. The sick note said, going blind. 2 words that devastated me, absolutely traumatized me. Was I going blind? Nobody had said that to me. Nobody. I was absolutely horrified. I can't tell you the damage that did to me. It was horrible. So please be conscious and careful of the words and the language that you use with your patients. I do still find that really quite upsetting to just relive that particular moment. My GP wrote on that because of a lack of education, I suppose, really, and just not knowing. It made me very anxious, and it made me want to try and carry on, but I was very, very worried and concerned about what my life and my outcome would be. You all work in a GP surgery, and I'm sure you have your list of patients who are asthmatic, your list of patients who are diabetic, you have registers for your learning disability patients. Do you have a register of patients with a sensory impairment? No. I would urge you to know your patients. I don't know whether you come from large practice or small practice, but even so, that really shouldn't matter too much. Know your patients. There will be, certainly within an older age population, a huge number, probably surprising number, of patients who have either diagnosed macular degeneration or undiagnosed. So ask your patients. Do it opportunistically. You've just gone through your flu season where you've had all your elderly patients in. Do your nurses know something about that patient that you perhaps don't know? Do your reception staff know that somebody always comes and they've always got somebody and they're always sort of conscious of corners? Little things that might give telltale signs that somebody can't quite see properly. Know your patients. Read code them. When I was a manager, we had a read code, bitten by a tiger. There was one bitten by a tiger. How many could there be read coded, visually impaired that you're not knowing about? So central vision loss is frightening, and it can lead to depression, and the quality of life that we all have can suffer. Barriers and difficulties to performing everyday tasks suddenly appear, and they have to be thought about and ways worked around in order to overcome them. Hopefully this is my opportunity to give you some tips as to how those barriers can be overcome in your GP setting. So as I've said, know your patients, read code them, create some sort of a register, know who your patients are. Get your staff to be aware. I'm sure the reception staff are the all-seeing, all-knowing within your surgeries. They probably know a lot more about the patients than perhaps you might do. Thinking about your waiting room and the layout of your waiting room. How accessible is that for your patients? Do you have an area where you've got toys? Is it just kept to one side, or by the end of the morning surgery, has it all overspilled and is strewn around the floor? What is your chairing like? What are the seating arrangements like? Are you in rows like this? Is it just all dotted around? These things are troublesome to a visually impaired person. We don't see quite as easily as you do. If somebody's bag has been left on the floor, chances are we may not see that. So think about the seating that you have and the layout. Think about the lighting. The lighting is particularly important in your surgery, both inside and outside. This time of year it's dark, the nights are fortunately pulling out a little bit, but end of November, December, when it's dark at 3:15 in the afternoon and it doesn't get light till maybe gone 9 o'clock in the morning. If patients are fortunate to have somebody who will bring them in a car, is your car park well lit? Is it strewn with potholes? Once you get into the surgery, again, is the lighting good? Part of my role is also I'm a CQC specialist advisor, and I have gone around lots and lots of different practices. Some of them have mood lighting to calm the patients. That's great, but I can't see a thing. It's too dark. Think about the lighting. It's incredibly important to us as a visually impaired person. We need good light. Think about the flooring that you have. Again, I know your practices and your premises may be very different from each other. Some might be in a brand spanking new purpose-built building. Others may be in a converted house. Think about the flooring that you have. Is it old, worn and tattered, and everybody knows that there's a bit of a tear there, so you all steer clear of it, or it's been, masked down? Is there lumps in it? Are there any stairs going up? Maybe even 1 or 2 stairs, from different levels. Is it well lit? What is the carpet like? Think about your walls and your decorations that you have. Walking from the waiting room down to the consulting rooms. What sort of signage have you got? Is it clearly signed? Oh yes, it's your name on the door. Can I see your name? Maybe not. Do you have it in Braille? Possibly. Think about also having colour blocks. It's far easier for me to see a red square on a door, or a purple triangle, or a blue circle. So your receptionist will say, go down to the blue circle door. That is far, far easier for me to see than go to Dr. Smith's room. These are all things that are really quite practical things for you to consider. As I say, the lighting for me is particularly important. How do your patients check in at your surgery? Is it one of these touch screens? Do they all have to do that? Do you have a manned reception desk anymore? Some practices don't. Some practices I've been in, they don't have anybody on the reception desk. What do your visually impaired patients do then? So always be prepared to make exceptions. We're not all the same. Think about that. I may not have either the confidence or the visual ability to actually see to do one of those screens. So have your reception team clued up as well to the fact that I may be coming along and I need help. How are your patients called from the waiting room? Do you use a JX board? Can your patients see that JX board? Do you make any exceptions? Should you have to make exceptions for me? Should I be an exception? Do you come and call your patients from your room? Do you stand at your room? These are all questions that I want you to have in your head to go back with and think about. These are all important things to me as I'm making the journey from the reception area down to your consulting room so that I can get to you safely. When I go down your corridor, are the door frames distinguishable from the actual walls? Can I see that I'm approaching a door? Simple things that make a huge difference to us with a visual impairment. When I'm sat in the waiting room, can I see the same amount of information that a patient without a visual impairment can see? Do I have to ask for it in a larger font size? Is it readily available for me? Do I have to ask for the practice leaflet in a large size? Why isn't it there on the side waiting for me just to pick up? Why do I have to feel that I am the exception? I hope some of you may have a patient participation group. They come in different names, different guises. the basis of which is that you have a group of patients and periodically you hopefully all talk together, and you might consider changes, and you may consider making amendments to policies, protocols, and even physical changes to your premises. Is there anybody on your group with a sensory impairment? Do you know anybody in your practice with a sensory impairment? These are things to think about and consider. Your appointment systems. Whoa, the bane of every GP practice. That's a big area, isn't it? Getting the right amount of appointments at the right time for everybody. It's not easy. But as I touched upon earlier on, as a visually impaired person, my hours of working and visiting and going out in this particular time of year are far more constricted. So if I were to ring up and say, can I have an appointment? And you say, oh yes, there's one at 5:20 in the evening. That would pose real problems for me. I would need somebody to come with me, which isn't always, I'm not always able to do that. I'd have to get on and off public transport in the dark, which isn't great. So you simply saying to me, come at 5:20 really isn't a great slot for me. So again, think about that. These are the kind of barriers that we have to face. Going out in the dark alone is frightening. Not knowing where your foot is going is frightening. I have fallen several times, and not just in the dark. And falling, certainly as an older person, isn't great. I fell in June and I broke my ankle, and it wasn't good. So, as I say, falling is a real worry for people with visual impairments. If you need to contact me, how do you go about doing it? Well, hopefully you might consider phoning me. You might consider emailing me or texting me. But if you have to send out a letter to me, how might you do that? Would you consider asking your secretaries, your admin team, to type it in a larger font size? Would you consider putting that letter on a piece of yellow paper for me rather than white paper, because I see better black on yellow rather than black on white? Little things that make a huge difference. Increasing the font size 2-3 times makes all the difference. Why should I have to give that piece of paper to somebody else to read? I'm not stupid. I can read a letter. I just need it to be in a slightly bigger font. So consider these things next time you're doing any kind of recalls or you're needing people to come in. That's what I said again. Read code your patients. Ask them, would you be offended if I sent you a letter in a larger font size, Mrs. Smith? I know that you're visually impaired. Would it help if I did it on a yellow piece of paper with the font size a bit bigger? I'm sure you would have a positive reply to that. When you contact secondary care on my behalf, do you notify them that I'm visually impaired, regardless of what it is that I might be going for? That's important. The hospital need to know that then whenever they need to contact me, I need that letter also in an accessible format. So thinking about these things makes my life a lot easier. Lots of patients, sadly, do DNA their hospital appointments. And then, as I say, a lot of that is because they can't see and they may not have got anybody at home to read that letter for them. But again, why should they be reliant upon somebody else reading their post? I would urge you to consider, as a whole practice team, having some sensory impairment training. This will give you all a taste of what it's like to be visually impaired in 2 or 3 different areas. The information and the help that you can give to your patients can only be improved, I think, if you've had just a small taste of what it is yourself. So put on a pair of glasses and all of a sudden you will have the vision that I have. And I'm sure you'll be absolutely staggered to think, crikey, how do people like this live with this 24/7 when you're only putting them on for 2 minutes? I think really that is all I want to say, particularly about travelling through the practice. I thank you for your time. A couple of my colleagues earlier on this morning mentioned NICE. I have had the enormous privilege of being on the current guidelines committee for AMD. The guidelines are due to be published a little bit later this year. Blood, sweat and tears have gone into making those recommendations. So I plead with you to look at them at least when they come out, please, and have some insight into what living with AMD is all about. Thank you very much.